Good afternoon, everyone, and welcome to Geriatrics Grand Rounds for the Division of Geriatrics at UCSF. I have the great pleasure of introducing today's speaker, my very dear friend and colleague, Dr. Annie Medina-Walpole from the University of Rochester. Just going to tell you a few things about Dr. Medina-Walpole. She's the Paul H. Fine Professor of Medicine at Rochester. She's also the Chief of the Division of Geriatrics and Aging, and the director of a quite new Aging Institute at the university as well. She's also current president of the American Geriatric Society. And so if you ever want to know anything about the inner workings of the American Geriatric Society, Dr. Medina-Walpole is your go-to person. You name a position at AGS and she's held it. Just a few of them are, she's the past chair of the teachers section. She's a past chair of the annual meeting program committee. And she is a past winner of the Dennis Janigan Award, which is the highest honor bestowed upon an educator by AGS. But what I suspect you may not know about Dr. Medina-Walpole is if you've ever been to a dance party at AGS, she is the driving force behind all of them. And you will always find her on the center of the dance floor. What I know about, and I'm going to call her Annie now, is that everyone she meets is left feeling better after having met Annie. She brings amazing joy and passion to her work. The people she worked for adore her, which tells you everything you need to know about her. And I'm delighted to welcome her today to talk about transcending the pandemic, the age-friendly health system's call to action. So welcome, Dr. Medina-Walpole.
Thank you. Boy, that was so lovely, Mike. And you are such a dear friend and colleague, and I'm just delighted to be here. It's hard to start with tears in your eyes, right? It's just an honor to present Grand Rounds today. I'd sincerely like to thank you, Dr. Walter, the entire UCSF Division of Geriatrics for inviting me to be a visiting professor. And I'm so glad I did it, even though it's virtual. It breaks my heart that I'm not there with you in San Francisco, but we're going to give it a go. And I look forward to meeting many of you that I haven't already met in the virtual meetings. So when I think back, I've been a geriatrician now for 25 years. That even astounds me. And I have found my work to be engaging, complex, intellectually challenging, and deeply rewarding. Geriatric health professionals like yourselves are experts in providing goal-based care to an aging population. Over the past 4 decades, our field has pioneered and implemented models of care and developed a robust clinical and academic knowledge base for identifying, treating, preventing diseases and consequences of aging itself. And so an age-friendly health system incorporates this rich evidence base that we have all developed, and it optimizes care for the older adults that we serve. I have no conflicts of interest. I am on the board of directors of the AGS. I do have funding from HRSA for our GWEP grant. So this afternoon, I'm ready to say this evening because for me it's 7 o'clock, but this afternoon we're going to review the Age-Friendly Health System Initiative. I'm going to share a patient case with you using an age-friendly health system framework, highlight some evidence-based age-friendly models of care that we actually have in Rochester, and illustrate opportunities after the pandemic of how we move forward with the age-friendly health system. So if I were a person, I would survey the audience. And this is really hard to do with a webinar because you can't raise your hands. So I'm going to ask some questions and I'm going to have to answer them for you. So perhaps you're here because you are aging. So we love our Rochester acronyms. Perhaps you're here because you like jazz music and you wanted to hear the song from the Eastman School of Music's New Horizons band. That was playing when you came in. That was the Clarinet Choir. This band is one of many across the country, I think almost 200, which are designed for older adults who have a love of music. The band consists of individuals who have no music experience all the way through to seasoned musicians. So I hope you enjoyed that excerpt. Perhaps you're here because you knew or you were mentored by Carter Catlett Williams or Dr. T. Franklin Williams. Frank was a remarkable figure in geriatrics. He was the former director of the NIA. He started Rochester's program in the 60s, and he was a mentor to countless geriatricians across our nation. Or maybe you knew his wife, Carter Catlett Williams. She was an equally esteemed and accomplished social worker who was an early advocate for restraint-free nursing homes. Perhaps you're here because you're a caregiver. Do you know that there's about 34 million Americans who provided unpaid care to an adult age 50 or older in the last 12 months? and almost 16 million family caregivers care for someone with Alzheimer's disease or another dementia. The age-friendly health system is for you. Perhaps you're one of our nation's almost 7,300 geriatricians, or you're a geriatrics trained health professional from another discipline. Or maybe you're a geriatrics educator or an aging investigator, and you recognize that this cute little creature, the naked mole rat, is actually an important model organism in studying longevity in the Rochester labs of Vera Gorbanova and Andrei Solunov. Or maybe you recognize Dr. Supriya Mohili or Karen Musty in her leading clinical trials in geriatrics and oncology. Or finally, perhaps you're here for a tale of two cities. So this is San Francisco and this is Rochester. And look, we have a bridge also. It's a bit smaller, but I was amazed at how the pictures look sort of similar. So perhaps you're here because you believe that we can make San Francisco and Rochester the optimal places to age in America, with age-friendly communities. Yes, they have those. Age-friendly universities, they have those too. And certainly age-friendly health systems. So let's get started. So I like quotes. This German author, philosopher, scientist, and statesman said, "Knowing is not enough, we must apply. Willing is not enough, we must do." So what do we know? Well, we know that the rapid growth of the older adult population poses unique challenges for our entire healthcare system. As people live longer, we have to adapt to the needs of this group and identify new and creative ways to provide high quality, cost-effective care. All right, so we knew all this. And then the pandemic hit and changed so many things. So to put this in perspective, I'm going to read you a quote from Sharon Inouye, who is a geriatrician who's devoted her career to studying delirium. This is from the New York Times. She said, "If you could design a healthcare system that would generate delirium, you would design exactly what we have with COVID-19, where patients are socially isolated, deprived of human comfort and communication, where staff are stressed, rushed, wearing protective equipment that obscures their faces, muffles their voices, where staffing shortages are severe, and sometimes only the bare necessity of care is delivered." That is why an age-friendly health system is so important. The age-friendly health system is an initiative of the John A. Hartford Foundation, the Institute for Healthcare Improvement, in partnership with the American Hospital Association and the Catholic Health Association of the United States. And I will tell you that I have never been more proud to be a geriatrician than during this pandemic, as hard as it's been. And I think there has never been a better time for an age-friendly health system. So an age-friendly health system provides older adults with the best care possible. This is the nirvana of older adult care. It follows a set of evidence-based principles. It causes no harm. It aligns with what matters to the older adult and their family and caregivers. And then value is optimized. And I just love this slide. So we are reframing our patient encounters. Instead of saying, "What's the matter?" we're asking, "What matters to you?" And I think that says it all. So when we look at the 4Ms framework, I know we're familiar with this, but I'm going to challenge each of you. This is our job. We need to role model these 4Ms for everyone. So what matters? As a wise geriatrician and mentor, Dr. T. Franklin Williams once told me, "When you've seen one geriatric patient, you've seen one geriatric patient." So care has to be individualized. We need to take the time to ask and learn what matters to each individual patient. We all know polypharmacy is associated with adverse events and burden, the form of morbidity, hospital admissions, costs, and that impacts what matters and mobility and mentation. So again and again, with medications, we know less is more. We need to role model this. The AGS has updated the Beers criteria. There are resources available for deprescribing. This is up to us to show the way. Delirium, okay, mentation, we think about, well, the 3Ds, so delirium, depression, dementia. But if you just focus on delirium, think about what Dr. Inouye said. Think about longer length of stay, mortality, institutionalization, again, impacting what matters. And mobility is equally important. It reminds us of the importance of function to the health and quality of life of older adults and the potentially devastating consequences of falls, bed rest, and immobility. So even a small gain in mobility, such as the ability to transfer, that can make the difference between having someone live at home or living at a higher level of care. So we know these things, but as the quote said, knowing is not enough. It's up to us to apply, and willing is not enough. We have to do. So the age-friendly health system builds on the IHI triple aim of better health, better care, better value. The components are synergistic, they reinforce one another. So really, you're supposed to assess and act on them, and they're meant to be integrated into every encounter of every older adult. And I believe really what's happening across the country, and certainly in Rochester, we're not perfect. We are still on this journey. But I think some of the M's are happening some of the times in some of the encounters. And it's been very difficult to really pull all this together and to do all the four M's in every encounter. So how can it help us? Well, averting all these terrible things that happen again and again and again in the hospital. Throw in the COVID-19 pandemic, and we have, it's even more important that we think about the four M's. And certainly that is your business case for age-friendly care. We want to avoid costs of poor quality care. We want to deliver care in a cost-effective manner. And so much of that is the what matters, implementing goal concordant care plans. And we want to enhance revenue from higher quality of care. So all of this can be very impactful at a health system level. So why wouldn't you be in? I think every one of us needs to be all in. I would argue that it supports every single health system's mission, vision, and values. It aligns what we're doing, critical quality and safety interventions to improve care. We need to increase utilization of cost-effective and goal-concordant services. And honestly, from the heart of a geriatrician, it is the right thing to do for the older adults we serve. So steps to becoming age-friendly, if only it was this simple. I love this. Ready, set, go. So ready, you're learning about it, okay? You inform the IHI you're interested. I think this is a critical step, is engaging a champion. So we have champions in multiple settings at multiple hospitals, and you need this to be successful. You send them an intent, you fill out a survey, you describe applications, you share your description, and then you share counts. Well, I'm here to say that in Rochester, we're doing this, but it's taken a while. It's taken a while to have buy-in. The pandemic has certainly slowed it down. And really, I was not willing to embark on this until it could be an age-friendly health system. I could have had an age-friendly hospital. Highland Hospital, our community hospital, would do everything. We do everything in geriatrics there, but I wanted it through the health system. So it took a while to engage all of the partners and all the champions. And now when we look at our baseline data, we're looking at four things. And I think the biggest challenge is pulling this stuff from the EMR. So what matters right now, we're looking to have an advanced directive documented, but we know that is just the tip of the iceberg. That's really not what matters to someone. So we're trying to figure out a way that we can have what matters on a daily basis documented with the EMR, and that we can abstract that data. We're looking at mobility assessments. We're looking at the CAM being done at least every 12 hours. And we're also looking at no high-risk meds prescribed. Well, let me tell you, if you include all of these meds, your numbers aren't going to be very good, and especially with opioids. So my point, I think, is we can skew the data, right? So I can just pick one, I'm just going to do antipsychotics for my 4Ms, but we're trying to look at the entire package. And I haven't shared this with anyone, but when we do this, our baseline data for assessing the 4Ms is only 15 to 18%. So we have a lot of work to do, and I feel that we're doing pretty well in Rochester. So I think my point is this is a journey. We're on this. There's always room for improvement, but I think the age-friendly health system is really important. So what I'd like to do now is share just a couple more slides. Again, Rochester is an age-friendly health system participant. UCSF, you already made it to level 2 recognition, committed to care excellence. And I think what's exciting is I just saw earlier this week or late last week that the Hartford Foundation announced that 1,900 healthcare centers or institutions are now participating as age-friendly health systems. So certainly it's not the entire country, but the momentum is building, and I think we have to continue this push. So to illustrate the importance of the 4Ms, I'd like to share a patient case with you and a story. So let's meet Mrs. Vela. This is Gogita Vela, and this is her at her 84th birthday. So we're going to meet her 2 years later. She's now 86. She's got Parkinson's disease, osteoporosis, osteoarthritis. Her family notes declining oral intake and weight loss. She's been more confused. She's been falling. She hasn't been injured yet. And they've offered to hire a home health aide, but she refuses. So her family's limited the visits. It's the pandemic, so they're trying to protect her. They're dropping off food. They're wading through the window, but they're really not going in. But on a recent visit, they did go into her room and they pulled open a drawer, and lo and behold, this is the geriatrician's nightmare, right? So we have all these medications. So they took the medications home and they pulled out all the expired medications, and this entire bag is almost filled with 300 milligram gabapentins, which are all expired. And she had been prescribed gabapentin by her primary care doctor, who was trying to treat pain and avoid opioids. All right. So let's look at Mrs. Vela in person. So let's meet her. And I think a picture is worth 1,000 words. This illustrates how much we can learn from seeing our patients at home, whether it's in person or now via telehealth. So when you look at Mrs. Vela, what do you see? And again, if I was there, you'd be shouting it out from the audience, but I'm just going to have to tell you what you see. Is she fit? No. Is she frail? Absolutely. When you look at her, I think the most striking thing is her face. She looks unhappy. She looks like she's in pain. She's kyphotic, so we've got a forward posture, perhaps putting her at increased risk of falls. She's arthritic. You can see arthritis in her hands. It's winter, but she's yet dressed for spring and summer. She's holding onto furniture, so she's furniture walking. If you see here, you've got her wheelchair in the corner she's not using. She's got one shoe on and one shoe off. I think this is the other shoe here. She's got some clutter, but she can move around. But again, this is a picture. So, I think we can learn a lot. And I tell our fellows, you need to observe as soon as somebody walks into the clinic. You can be assessing and you can be learning about them. There's so much to learn from observation. So let's look at her through an age-friendly health system lens. To Mrs. Vela, what matters is maintaining her independence, staying in her home, seeing her family. She wants to walk her dog. She has 2 small dogs. She's been falling. She's afraid to fall. Sometimes she can't get up for a while. For her mentation in mind, she thinks nothing is wrong. But her family has concerns. They're concerned with memory loss, maybe depression, and now she's socially isolated. She is widowed. Medications, well, she'd like pain control, but she wants as few medications as possible, as evident by what she's been putting in her drawer. So we're concerned with polypharmacy and medication mismanagement. So I think Mrs. Vela also illustrates another really important point, that in geriatrics, there's a 5th M. So the 5th M of geriatrics is multicomplexity. This incorporates multimorbidity, geriatric syndromes, complex biopsychosocial situations. This is why each and every one of you is a geriatric superhero. Okay, this is the art, this is the nuance, this is what we bring as geriatric health professionals. And I want to keep in mind the 5th M, because I think that's really important for Mrs. Vela. And to illustrate the 5th M, I'm gonna look through her syndromes. So we have polypharmacy, we have some falls, we have cognitive impairment, we have isolation, we may have depression, but I'm going to focus on frailty. And what does frailty portend for Mrs. Vela? So frailty is a physiologic syndrome. It results from dysregulation of multiple systems. It's manifest when your physiologic dysregulation reaches really a critical threshold and there's a decreased ability to maintain homeostasis in the face of stressors. So really, frailty is vulnerability. And this is a very simple slide, but I like simple slides. So if you have someone who is relatively independent, they have an illness, there might be an infection, there's a small dip in their functional status, but they recover pretty quickly and back to their prior level. Someone like Mrs. Vela has a larger dip. It takes her much longer to recover, and she may not get back to that same level of functional status. So if we really wanted to examine this, we could use frailty as a physiologic process and use Linda Fried's criteria. And again, I'm not going to read through every one of these, but I bet Mrs. Vela has 3 or more. Losing weight, feeling exhausted. I think it would take her a while to walk 15 feet. And so frailty is going to play a role in Mrs. Vela. So you know where this is going, right? She's found down by her neighbor after falling in her yard. She's transferred to the ER late on a Friday night. She's diagnosed with rhabdo and an acute right femoral neck fracture. And thankfully, she tests negative for COVID-19 in the ER. She's admitted to the orthopedic surgery service. She has an IV placed, a catheter is placed. She's put to bed rest. And oh my goodness, we hear an echo in the ER. There's a soft systolic murmur. And so a cardiology consult is ordered. And her surgery is delayed. It's the weekend after all. She has to undergo some cardiac preoperative testing. She becomes fluid overloaded. She becomes agitated. And on hospital day 4, she undergoes surgery. So let's again look at Mrs. Vela through an age-friendly health system lens. So what matters? Nothing has changed for her. She still wants function, home, independence, and family. For mobility, now she's at bed rest. We've tethered her with the Foley catheter, and I'm sure there's bed rails. Her surgery is delayed. She's probably becoming delirious. She's getting agitated. There's COVID in the hospital. Her family can't visit. And now we've got pain meds, which are certainly appropriate, but we've got anesthesia, we've got diuretics. So again, let's not forget the fifth M. With surgery, we know there's many studies that show preoperative frailty is significantly associated with postoperative complications, so longer hospital stays, higher 30-day mortality. So what could be different in an age-friendly health system? So I'm going to share with you, this is my favorite slide. I use this in every talk that I can. This came from Linda Freed and my mentor in Rochester. I know he is beloved at UCSF also, Bill Hall. And this was a letter to the editor that they wrote entitled Leading on Behalf of an Aging Society. And I love that. And this is the models of care. So in this instance, I'm thinking about the building blocks for an age-friendly health system. But in others, just a call out to the fellows, students, junior faculty. Look at what we do as geriatrics health professionals. So we care for older adults from when they are robust until end of life. And look at all the various settings. We do so much. Your career can go in so many directions. And I think this is just a very powerful slide. So I took this slide and I went to your website at UCSF. And I thought I would show you how you are leading on behalf of an aging society. So, wow, are you ready for this? Look at what you are doing. Hats off, a round of applause, a standing ovation for UCSF Geriatrics. So I put all the programs I found for the VA in green, everything else in red. I'm sure I'm missing some, but look at this. This is quite incredible. These are the building blocks for an age-friendly health system throughout your entire city. So congratulations. So then I thought to myself, after I made this slide, what am I going to talk about? What can I bring from Rochester that's maybe a little bit different? And not to say that you don't have some of the programs here, but what can I share? So I'd like to share with you some of our models of care that are really our building blocks. So it's the co-management, the Geriatric Fracture Center. I did speak with Stephanie Johnson. I know you have a program at your university hospital that many of you are involved in. We're going to talk about the Hospital Elder Life Program to prevent delirium. And we're also going to talk about Project ECHO, which is Extension for Community Healthcare Outcomes. And we're going to look at the Project ECHO we have in geriatric mental health and also COVID-19. All right, so the Geriatric Fracture Center started in Rochester, and we're very proud of this. So annually, there's about 300,000 hip fractures, and in Rochester, we take care of 1,000 of them, about. And we take care of more of them in Highland Hospital than any other hospital in the region. Highland Hospital is a 261-bed community teaching hospital. And over the past 2 decades, it's really developed as Rochester's premier hospital for geriatric care. It's kind of like the little engine that could. The chief of medicine is Bob McCann, who is again my mentor. Bill Hall is there. About 1/3 of our division is there. And everything that's happened in geriatrics, every model of care, the ACE unit, the fracture center, the health program, it's all happened at Highland Hospital. And in a large part, it's due to Bob McCann's leadership, but it's also because Highland Hospital has been the recipient of all our educational interventions with the Reynolds Foundation, with our Hartford Center of Excellence. We've devoted our work to that hospital. So in 2004, the Geriatric Fracture Center was launched by Dr. Daniel Mendelsohn, who's a geriatrician that many of you, I'm sure, know, a close friend and colleague, and also Dr. Steve Cates, an orthopedic surgeon. And again, they realized, I think what we all know, if you communicate and you work together, care is improved. But they were actually able to show decreases in time to surgery, decreases in mortality, decreases in length of stay, cost, infections, all of these things when they work together. So they launched the Geriatric Fracture Center. And the hallmark is really, we're targeting fragility fractures. We are not a tertiary care center. That hospital is called Strong Memorial Hospital, about 2 miles down the road. I'm going to tell you about Strong in a minute. So these are fractures that occur from a standing height or lower. This is patient-centered, protocol-driven, team-based interdisciplinary care. And the hallmark, again, is the co-management between geriatrics and orthopedic surgery. So what does co-management mean? It's a care delivery model where geriatrics health professionals, so either geriatricians, geriatric nurse practitioners, or specialty trained geriatrics co-managers. So these could be hospitalists working with surgeons to coordinate and improve the perioperative care of older adults with hip fracture. So the idea is that you are proactively identifying and addressing risk factors for harmful and often iatrogenic events. So we optimize these, and again, very favorable outcomes. And what I love about this slide is all of these services are involved, but at the center is our patients and their families. And again, focusing on the what matters. So as Dr. Mendelsohn would say, the sincerest form of flattery is imitation. And this model has been reproduced at sort of countless institutions and hospitals nationwide and internationally. Now, if you don't have a co-management program at your hospital and you would like to, you can have help. So I'm going to talk about AGS Co-Care Ortho. So this is a product of the American Geriatric Society with support from the John A. Hartford Foundation. And what they have done for you is come up with resources, products, training, and technical assistance. And I'm going to share with you how this actually worked for us. So Strong Memorial Hospital is 2 miles down the road, and you would have thought it could have been easy for us to develop a fracture center there. We don't have geriatricians there. We have sort of a half a position embedded in hospital medicine, but there's no, we had to partner with hospital medicine to make this happen. It was not as simple as Daniel saying, here's the order sets. Here, I'll train your people. We needed a buy-in, we needed a business plan. And in order to get hospital buy-in, it was very helpful to have the AGS co-care resources. And it was helpful to have the hospital invest a small amount of money because there was stakeholder buy-in. And then it wasn't myself and Daniel holding the folks accountable. It was Lynn McNichol from Brown. And so this for us was a way to be successful. And I can share now that 2.5 years later, we have ortho co-management, we have trauma co-management, and it's all because of AGS co-care and those resources. And we are JACO certified and getting very similar outcomes to what we continue to get at Highland Hospital. So again, I'm a big believer in this. So I want to share with you, in an age-friendly hospital, what should be happening? What should be happening on that fracture center? Asking what matters, documenting in the care plan what matters, reviewing medications, screening for delirium every 12 hours. And again, screening for delirium can happen. We have our nurses are screening for delirium, but if the healthcare providers are not looking at those screens or not using those screens, it's really not helping the person. So a lot of this is a coordinated effort. Screening for mobility and then acting on all of these things is what happens in an age-friendly health system. This is a slide which is courtesy of Jenny Shen and Val Ling. They are 2 hospitalists who are working at the Fracture Center. This is a figure that they're submitting actually in an article to JAGS showing how they are doing 4M's care on the Geriatric Fracture Center. So again, we're working very hard in Rochester to do this as a package deal. So how can a co-management model contribute to an age-friendly health system? All of these things. All of these things make a huge difference. This is Dr. Daniel Mendelsohn. I had to include his photo. And again, the end, when we think of the IHI, triple aim, quality, cost, patient experience. And the most important to me is what matters to the patient. All right, so let's move back to Mrs. Vela, because we know she's not at the Geriatric Fracture Center. So postoperatively, her course is complicated by delirium. She pulls out her AV, she tries to climb out of bed. Well, they put a posy vest on her, they give her some benzos, and on hospital day 9, she's discharged to the nursing home. So when we look at the age-friendly lens again, it hasn't changed for her. But now we have restraints. She needs skilled therapy. Can she participate? She's delirious. She remains isolated because her nursing home has COVID. We've got pain meds, anesthesia, diuretics, benzos, and we're concerned that she will be started on an antipsychotic in the nursing home. So when we think about Mrs. Vela again, let's think about that 5th M. We know she's frail. She's developed delirium. What's the impact? So this is a study from, it's 2012 prospective cohort study that explored this in 273 older people admitted to a general medical service in South Wales. They followed patients for 5 years. Median survival was significantly longer in those that were fit than those that were frail. But when they looked at patients who had delirium, survival was significantly reduced in both, but those that had the combination of frailty and delirium conferred the worst prognosis. So again, I know I'm painting a terrible picture for Mrs. Vela, but this is a good way to illustrate that the best prevention or the best treatment for delirium is actually to prevent it. So this is another AGS co-care program. So AGS has really taken on programs to package them and make them easily disseminate them to you. Co-Care Help is the Hospital Elder Life Program. This was developed by Sharon Inouye in 1999, and Sharon is now a huge part of this at AGS and really wants her program to be out there. We know the benefits. So it's a comprehensive program. The goals are to prevent delirium in the hospital, maintain physical and cognitive functioning, maximize your independence at discharge, so hopefully you can go home rather than a higher level of care, and then prevent unplanned readmissions. And this is Sharon, so I'd like to do a tribute to her because her work has been just instrumental to our field. So HELP has a really innovative staffing model. So there is an elder life specialist. This is a person who runs the program, who trains the volunteers. It's about a full-time position for this individual. We have a nurse specialist at a half-time position who is really a liaison with the nurses on the floor, doing a lot of nursing education. And then you have a very small piece of a geriatrician, maybe a 0.1 FTE, to help oversee the program. But what's unique about this is the workforce is volunteers. And in Rochester, we do have this program in Highland Hospital, and we have a large amount of medical students and nursing students. These are some nursing students here that participate in this program. So again, you have the cost of starting the program and the cost of some of the leadership, but the actual workforce is free, and that is huge. So again, this is another way to look at the model. Again, what matters to the patient in the center, we have the elder life specialist, the nurse specialist, and then all of the other touch points and all of those involved. So again, everything we do in geriatrics is very interdisciplinary, a very holistic goal-based approach, and that's why I love this program. So HELP focuses on protocols to manage 6 risk factors for delirium, which include cognitive impairment, sleep deprivation, immobility, visual and hearing impairment, and dehydration. So typically there's once to twice daily visits by the volunteers, and all of this goes on for the individuals in addition to nursing education. So when we look at outcomes, Sharon Inouye showed 5% reduced delirium incidence back in 1999. I'm just going to take you through some of these. A decrease in functional decline, decrease in sitter use, which we know can be quite costly, a decrease in institutionalization after hospitalization, reduction in falls, reduction in length of stay, reduction in postoperative delirium. So these are very real outcomes, and they translate to cost savings. So the average savings per resident in the hospital is about $1,000. And again, the financial return is based on cost savings by reducing all of these variable costs. So delirium cases prevented, revenue generated by backfilling of beds that are now available due to delirium prevention and shorter length of stay. And when we look at some of these studies, they really, they range 831 to 1,000. I think the most famous study came from Rubin. This was from Shadyside Hospital in Pittsburgh. His metrics showed $7.3 million savings per year in hospital costs, about $1,000 per patient. So very significant savings. And again, a pretty nice business plan to take forward. So at Highland Hospital, our program is small. So unfortunately, with the pandemic, we did not have the bandwidth to be able to transition as many programs did to telemedicine or telephone visits, but we're starting that up again. So to date, we had trained about 267. There's usually about 30 active volunteers at one time, and that varies. The average age is 84. We've done 22,527 interventions. And what I love also is that all these unofficial visits. So these volunteers are committed. They are coming in other times of day, other days to actually see these individuals. We've reduced our length of stay. It doesn't look that significant when you compare without and with delirium. But again, this was in the hospital. I think we have started to move this into the OBS unit. So a few years ago, many patients went into the OBS unit. They were not initially included. So the longer length of stay certainly impacted us. And we've reduced the percentage of delirium from 7%, kind of low to start, because again, we had geriatricized Highland Hospital, to anywhere from 1.8 to 2.5%. So again, a very successful program. So we now are participating in Co-Care Help. And what we need from Co-Care Help is more the business plan, so I can take this model to Strong Memorial Hospital. And we also need, we have never done a cost analysis of this. And so those are the next steps for our program. So we can work on disseminating it in other hospitals in our region. So I also want to share at UCSF, I found you have a collaborative delirium prevention in the age of COVID-19. This was published in JAGS. So using your usual delirium careway pathways, but also many, many other things that you are doing to prevent delirium. So again, hats off to you. You really do have an amazing program. So thinking about how delirium prevention programs contribute to an age-friendly health system, all of these reasons. So finally, quality, cost, improved patient experience. So let's go back to Mrs. Vela. So in the nursing home, she has a persistent delirium. She refuses meds. She becomes combative with care. She's in therapy and she picks up her walker and she shakes it. And, you know, you can't have that. And so she is rehospitalized. And unfortunately, she tests positive for COVID-19 in the ER. So this is not what we want to happen. But again, this is not an uncommon scenario. So the final thing I'd like to talk to you about is Project ECHO. Project ECHO stands for Extension for Community Health Outcomes. Again, we're going to talk about geriatric mental health and the COVID-19 Action Network. Project ECHO is a hub and spoke model. So the hub, it links expert teams at a hub, which is usually an academic medical center, with primary care providers or teams in local communities. So whether those teams are primary care offices, whether they are departments of health, or whether they are nursing homes. And what you do is you increase workforce capacity. So the specialists often can't travel to these rural sites. It's web-based video conferencing and telementoring. So this was Zoom. You know, before Zoom was a thing, before we were on Zoom every minute of every day, we were doing Zoom with Project ECHO. There's case presentations, didactic, there's CME. And what's really amazing about this and what has been so rewarding is you promote subspecialty expertise over time. So when we've done this in the nursing homes, I'm the geriatrician on the ECHO call. I'm about to say what I feel is going to be something profound. And guess what? One of the nursing home team members says the very same thing, because we've been learning together. This is an all share, all learn model, and nothing can be more heartwarming and rewarding. So Project ECHO, I want to give you a little bit of the history because I know at UCSF you have a hepatitis C ECHO. And Project ECHO actually started at the University of New Mexico in 2003, 2004 by Dr. Sanjeev Arora, who was a gastroenterologist. So he was treating hepatitis C. There was about 28,000 cases in New Mexico at the time, and less than 5% of patients were treated. They all couldn't travel to the university hospital. So he did a prospective cohort study comparing treatment for hepatitis C infection at the University of New Mexico Clinic, and also via ECHO at 21 sites in rural areas and prisons across New Mexico. What he found is that he was able to show he could obtain similar outcomes. So no significant difference in detectable virus 6 months after completion in sites that were at the university versus sites that were at the ECHO clinic. And so Project ECHO was born. So now Project ECHO is all over the world. This is a blow up of the United States. Here we are in Rochester, and here you are at UCSF, and you can see the super hubs are training. The hubs are the programs. So again, widely disseminated in all sorts of ECHO. So in Rochester, we have ECHO eating disorder, ECHO autism, ECHO HIV, STD, ECHO hospital medicine. We had an ECHO palliative care, in addition to some of the geri-psych ECHOs I'm going to talk to you about. So Project ECHO for Geriatric Mental Health started in 2014, and our Division of Geriatric Psychiatry wanted to assist primary care practices because there wasn't enough geriatric psychiatrists to get out and to see all these folks in consultation. So this is a geography lesson for you. This is New York. So here's New York City. We are almost 5.5 hours away in upstate New York, in Western New York. So we're between Buffalo and Syracuse. And these are the Finger Lakes. So this is the catchment area of the University of Rochester. And the Finger Lakes is actually our wine country. It's not California's wine country, but we do have that. Okay, so we started with the geriatric psychiatry program to primary care sites, and this is the outreach. So this is what ECHO can do across the state. So you can look at the reach all the way up to Clinton County, almost to the city, sort of in the Catskills, and all the way into Western counties, southwest of Buffalo. And this program resulted in reduced medications, reduced hospitalizations, reduced ED visits, and was very, very popular. And so at the same time, we realized that the regional nursing homes also had a lack of geriatric psychiatry. This was at the time that they were doing Medicaid reform in our state. And so one of the projects was Project Echo to nursing homes. So they started with a needs assessment. And if I blow up this, again, this is our catchment area. If I blow this up for you in blue, these are counties that are in need of geriatric mental health services. In red, these counties lack mental health services by geriatric psychiatry entirely. So you can see the need. And when we looked at where things are in the nursing home, not so good. 1 in 5 residents getting antipsychotics, lots of hospitalizations, lots of mental illness. There was also an existing ECHO model at Harvard. This was the Geriatric Mental Health and Dementia ECHO. It went to New England nursing homes associated with Beth Israel. They saw a 34% reduction in antipsychotics, 60% reduction in hospitalizations. So our geriatric psychiatry program took this on. So this is the hub. There's a geriatric psychiatrist, a geriatrician, we have a psychologist, social worker, pharmacist, nurses joined us. This is what it looks like. It's not a fancy suite. We have a poster in the background. This is Dr. Michael Hasselberg. He is really the brainchild behind all of the ECHO, and now he is leading digital health for our entire medical center. This is EJ Santos, who is the division chief in geriatric psychiatry. These are students. There's always students with us. And I have to do a special shout out to Dr. Lisa Vargas. Lisa Vargas actually is a graduate of the UCSF Family Medicine program. She's been in Rochester for many, many years. She's our fellowship director and she's a Tideswell scholar. So this is what it looks like. So in 2015, we recruited about 60 nursing homes for weekly clinics, and the nursing homes would present patients actually. There would be new case discussions, we'd have didactics, we'd do follow-up cases. And in 2017, this was so popular that we added another 90 across New York State through the New York State Office of Mental Health. So we have 2 echoes going on simultaneously on different days. And there's been interprofessional education, CME, and there's been no cost. So it was initially funded by the Medicaid reform in New York State, then it was funded by grants, and now it's incorporated into our web grant. And so as you can imagine, the evaluations from the nursing homes is sometimes hard to get. When we did satisfaction surveys, people like it. We knew they would. People felt more supported. Subspecialty expertise certainly did develop. And then they tried to look at quality indicators, the CMS quality indicators, looked at deficiencies. And what they found is, the findings are good. Not a lot of statistically significant findings, unfortunately, but we did see that 86% of case patients had symptom improvement as documented by the nursing homes. There was a decrease in a lot of benzo use, restraint use, antipsychotic use. The only thing significant when compared to control nursing homes was restraint use. There was no hospitalizations of case patients by the time they had the follow-up presentation, which was usually 1 to 2 months later. And then providers really felt a decreased sense of isolation. They felt supported. And again, provider is not necessarily the physician in the nursing home. These are the care teams that were on the echoes. So just to show you a couple slides, this is the antipsychotic slide. So again, here's the New York State average. Here's the Finger Lakes region. Don't like to show that, but this is what it was. We brought it down to just about or just below the state average. This is one nursing home success story. And again, everyone counts. So at one point in 2017, over 35% of their residents were prescribed an antipsychotic, got it down to 11%, which is really quite incredible. And then the other thing that came of this program, this reminds me of the building blocks again. So we had the telementoring, which was the tele-echo. And so the department or the division of geriatric psychiatry are quite creative. They said, we need to do telepsych. We need to have a nurse psychiatric specialist that can go out to some of these nursing homes, help with care plans. So now it's really the trifecta, and they have built a very comprehensive program that they are taking across New York State with the ECHO, telepsychiatry, and on-site engagement. So just a great group of colleagues and really innovative and really proud to be working with them. So let's speed ahead to August 2020. All right. So in Rochester, we made it through the first surge of the pandemic. Things had actually settled down quite a bit. And Health and Human Services announced that they were allocating CARES Act Provider Relief Fund for nursing homes. And then this came. So Project ECHO, this was happened rather quickly, but the University of New Mexico was partnering with HRQ, with the Institute for Healthcare Improvement, to really find people or find hubs who were interested in developing the COVID-19 Action Network. And in Rochester, we were all in. We love ECHO. We were excited to have a new program. And I know at UCSF, Misha Yukawa and Candice Kim are participating and running a cohort for the Stanford COVID ECHO. So it's wonderful that you're doing this too. It's been an incredibly rewarding program. The goals, essentially what you would expect. Let's prevent COVID from entering the nursing home. Let's prevent its spread. Let's be able to identify infected residents and staff, treat residents in place if we can, improve knowledge, implement safety practices. This is a year-long program, so this is week 15 for us. So the first 16 weeks was really an interactive virtual community of practice, almost like a boot camp, followed by office hours for the next 36 weeks. We meet for 90 minutes a week, and we are running 2 echoes. So we have 70 some nursing homes that are participating. And what's nice about this is the IHI has given us the package. So we have an expert video presentation, and these are from experts throughout, geriatricians, geriatric nurse practitioners. We had a presentation from a CNA. So it's a very interdisciplinary approach. We've all been assigned a QI coach. So ours is from NYU. She has her PhD in health policy, and she is doing live presentations on quality for the nursing homes. And then it's a facilitated discussion of challenges and successes. And what's exciting for the home is you're incentivized $6,000 to each home if 2 people attend the first 16 weeks. And then to the hubs, it's $6,000 per nursing home back to the hub. And I will tell you, in the time of COVID and austerity budgets and faculty who were tired but excited for something new and different, this was really rewarding to be able to bring a little revenue back to our division. So how can Project ECHO contribute to an age-friendly health system? So increasing access to subspecialty expertise, disseminating best practices, education, quality metrics, and again, a building block for some innovative new programs like they did with psychiatry. So improve quality, improve cost, improve patient experience. So let's finish with Mrs. Vela. And this is sad. You know, she returned to the nursing home. She had a prolonged delirium. She couldn't participate in rehab. She remained isolated from her family. She developed complications of COVID, immobility, frailty. She got deep tissue injury to her heels, a DVT, and she expired on hospice 3 months after her original fall. Unfortunately, her family was at her bedside. So I think there's a lot that we can learn from Mrs. Pela and certainly from this pandemic. And you could have grand rounds every single day of the week talking about what we can learn from the pandemic. And I think we need to continue to move our health systems forward, utilize what we've done. People have been so creative to optimize the care of our patients, to keep the academic mission going. So the first thing we learned, and I think we knew, delirium and adverse outcomes in hospitalized patients with COVID-19. So a lot of these articles are from JAGS. I have been so impressed with the work that has been done in geriatrics. So this was a Brazilian study of 707 patients admitted to the acute hospital. Delirium identified in 33%. So we know it's high, associated with in-hospital mortality, which this slide shows. In red is delirium, blue is no delirium. And then again, increased length of stay, ventilator utilization, admission to the ICU. We also know that frailty and social isolation are associated with mortality. So this came from the Netherlands. This is part of the longitudinal study of Amsterdam, looked at over 1,400 community dwelling older adults aged 65 and older. So when they looked at the intersection of frailty, loneliness, and social isolation, they looked at these individuals. And what they found is if you were frail and lonely, together you had a worse prognosis, and likewise frailty and social isolation. So that, I guess that doesn't surprise us when we think of Mrs. Vela, but what interventions could we have made? What could we have done differently? Well, UCSF, again, you're rocking this, social isolation and loneliness during the COVID-19 pandemic. So your GWEP has developed 10 to 15 minute on-demand videos for healthcare professionals. So this is incredible. And again, hats off. Other things, this came out of the Healthy Aging Special Interest Group at the AGS. So how to promote healthy aging during COVID-19. So this is a very thoughtful piece. It shows you the healthy aging framework and gives you some nice tools and pearls about things you can think about for your patients during COVID-19. When we look at other things, rapid integration of home telehealth visits among COVID-19. You know, telehealth can't go away. This is our window to patients. And I think if we can make this continue to happen, it's very important. This came out of the Boston VA. Home visits, two-dimensional view of the geriatric 5Ms. I just loved this. This came out of the Bedford VA. And here from UCSF, adoption of video visits during COVID pandemic by VA-based home-based primary care. We look further using telementoring to share best practices on COVID-19. So this was an echo before the COVID Echo Action Network. This came from University of Chicago, Lauren Gleason and Kate Thompson. The Hospital Elder Life Program, Sharon Inouye in long-term care. And then John Morley and his crew, applying the age-friendly health system framework to long-term care settings. So again, so many ways to move us forward. And then finally, the academic mission. So just the creativity that happened. This is a medical student curriculum with the 5Ms, again, from Allison Nishner, from UPenn, Staying Afloat, the Geria Float, just a wonderful program that I'm sure all of our fellows are participating in. And finally, this came from UCSF as well, Succeeding in Aging Research During the Pandemic, Strategies for Fellows and Junior Faculty. So the academic mission is important, and you have been so creative, and we need to keep this going. So I'm going to conclude, you know, how do you sum up all that? Really, I think the care of older adults can be optimized in an age-friendly health system. Have we figured it out completely? Absolutely not, but we are on a good journey. And there's also so much to learn from the pandemic as we come out of this second surge. Let's take action. Let's move forward together. So this is really a charge to you. This is your call to action. I really think the time has come for an age-friendly health system. Whoops. And you can make a difference. You can be a change agent. And it's really, again, back to that quote, it's not enough to know. We have to apply what we know. And it's not enough to will that this be done. We have to do it. So I'd like to acknowledge my division, the Geriatric Psychiatry Division, the AGS, IHI, Hartford, Project Echo. And I'm going to leave you with a quote. So this came from my close friend and colleague, Susan Friedman, who's a geriatrician in our division. And in many cultures, it's a blessing to reach 100 years. So may you live to be 100. May you live to be 100 years with one extra year to repent. May you live to be 100, and may the last voice you hear be mine. I love this because I have a daughter who is a jazz singer. And good luck, good cheer. May you live 100 years. And I added, and may your care be in an age-friendly health system and from a geriatrics trained health professional. So thank you so much. It's been an honor to talk to you, and I'm going to unshare my screen, and I'm happy to take questions.
Fantastic. Oh, that was so inspiring about the breadth of all the stuff that's being done. So that's just really inspiring. I have a couple questions from the audience that I will ask. I'm going to group a little bit. There's a couple about the hospital elder life program. So
yes.
One was a little bit about what are the qualifications of an elder life specialist. And another one was around, you know, during the pandemic, it's been really, there's like a lot of no volunteer policies. Any recommendations for how to start a help program, you know, in this kind of environment?
So the first question, I think the elder life specialist, I don't know that there's specific qualifications. In our institution, it was someone who had been a prior volunteer coordinator. So I think there's people skills, but it's really more program administration. I suppose they could be a nurse. I don't know that there's not, but there's a specific role for the nurse, but it's really someone who is going to organize the program, somebody who's good with data. I can certainly share some more. I know on the co-care website, there is all sorts of, you know, they have job descriptions for each of these things. So I think because we started it so many years ago, it was this person just fit right in. And so that may not meet the exact criteria. During the pandemic, I know people are doing telephone visits, they're doing telehealth visits, but it's hard to get something like that started. So I think it's important. I think you can be creative. The other thing people have done is they've redeployed people in the hospital. So maybe you don't have volunteers and maybe there's an increased cost. Now I know we are suffering a severe nursing shortage in our hospitals, in our nursing homes. So there's not a lot of extra bodies to be had at this point, but perhaps as hospitals are starting to open up again, I know our hospitals have just opened up to visitation. It might be time to get the project going. But again, I think a lot of times in Rochester, we sort of just made these, you know, we just sort of did these things. And I feel that there really is something now to a business plan and being much more strategic And so I think starting with the tools, I think it would probably take several months to get the project going.
Mhm. Terrific. And this kind of builds on to questions about the cost to organizations to get help from AGS in terms of like the co-care ortho or
Pull out my sheet.
oh,
I have the
excellent.
I have the cost. I have the
Is
cost. All right.
there-
So I confirm this week. So adopting any of the co-care programs, it's $5,000 for a 2-year implementation subscription. So again, that's not insignificant, but if you are going at it from a hospital or a health system and you can show the business plan for cost savings, I don't think it's that significant. And then there's an annual subscription of $1,000 to stay connected with the program. I asked if there was a sliding scale because there may be hospitals that are smaller, rural. They said they don't really have a sliding scale, but they certainly would be willing to talk to people. And then sometimes you just need the Getting Started Toolkit to be able to build your business plan. And they share those for help. It's $250. For AGS Co-Care Ortho, it's $350. So I think the idea is these are not money makers for the AGS. Really, I think what you're paying for is the staff time to sort of coordinate this, but it's so important. Just speaking from AGS Co-Care Ortho, it made a huge difference. I don't think we could have done it without this. And the training modules alone, I think are worth that.
Yeah, I'll put a plug in there. We use the ortho co-care module here to start our program at UCSF. So it was super helpful.
Yeah.
And then I guess some other questions. One was more on like terminology. So you hear about a lot about the age-friendly health system. Before we were hearing a lot about patient-centered care, like you could be a patient-centered care. Sort of thinking about how do those two things overlap, or I guess how do you think about that? Are they kind of separate constructs, or how do you?
I think the age-friendly health system is patient-centered care, but I think when you said something was patient-centered, it kind of, I think we did what was, we sort of did it for the patient, but I'm not sure we asked the patient what was important to them. I think that might be the difference, that I feel that the age-friendly health system, the what matters piece, is we're really engaging with the person. We are asking them what matters, and to them, what matters might not be, something that we would think, that they want. And so I think it's absolutely patient-centered, but I almost think it's a step beyond, because we're taking the time to see, how we can make it more patient-centered to that individual person. So perhaps it's a bit more individualized than this, patient-centered is kind of a catch-all term that we all use because we all want to be patient-centered, but I'm not sure we always are.
Right. I guess the other, this is a question I don't know if you know the answer to, but I'm curious about why did IHI drop the 5th M, right? When I'm presenting, I often talk about multimorbidity in the 5th M, and I noticed in your presentation, you talked a lot about the 5th M. Any background on that, or?
I think perhaps, and I don't know the whole story behind this, but I think perhaps it keeps it a little bit cleaner. So multimorbidity, multicomplexity, and maybe that's something, maybe people don't want that, right? So maybe, look, I want to talk about my medicines. I'm not multimorbid. It sounds horrible. And so maybe, but for me, that's the nuance. That's what we do as geriatricians, right? And so I think, so I try to keep it separate. I believe in the age-friendly, but I have to bring in the geriatric 5Ms because we can't discount what we do, but I don't know the full story of why. And I didn't actually know it was dropped, I'm sure, yeah, where did it go, right? But I think when people talk about it, they continue, we as geriatricians continue to bring that in.
And then I guess just the last question is, the pandemic has obviously shown the importance of geriatrics. How do we use that to just really megaphone out there how we can be helpful, for policy and care? And, we're a small group, but I'm just thinking about, what all has AGS done in terms of getting, the importance of geriatrics out there. What as individuals can we do? I mean, certainly in UCSF, we have a lot of different people on, committee stuff, but thoughts on that?
I think it's a grassroots effort. So I think, honestly, in Rochester, because we weren't, so I told, I think the fellows this, we have a new chairman of medicine. She said, Annie, why is your office in the county nursing home? I said, oh, Ruth, it's going to take a long time to tell you the history here. But we were never at the main medical center. So I think we were sort of out of sight, out of mind. And honestly, we were leaps and bounds ahead because we were already integrated into the community. So now we're sort of the squeaky wheel. Now everybody is, oh my goodness, long-term care makes a difference in COVID. Oh my goodness, look what the geriatricians bring to the table. And so this has been a journey I've been on. I think that we are the voice and face of geriatrics. We have to embed aging. And, you know, back in the day of the Reynolds grant, we used to say, oh, this is stealth geriatrics. We come in and we're going to, you know, we're going to sort of slip in our education. And now it's front and center. You need us. And I think health systems are seeing that. And I think our worth is here, and they're seeing what we can do, but a lot of what we do is off the radar too, right? So all the admissions that we prevent, nobody knows, right? They don't know who doesn't go to the hospital. They only know who goes to the hospital. So we are doing so much work. So it's not even being a squeaky wheel. It's about educating, and it's about being at the table. And so I'm doing some serious advocacy. We have associate CMOs, or sort of associate CMOs in all these areas. And I said, where is the one for post-acute and long-term care? And so I think we have to advocate at our own institution level, and people are listening, and we clearly have a seat at the table now. On a national level, there's a lot to be done too. And I think the AHS, you know, we advocate at the federal level. We can't advocate at the state level because we're not large enough to do that. But I think we are doing some major initiatives, certainly with telehealth, certainly with advocacy for payments, certainly to keep the interprofessional education going, you know, more money for GWEPs, more GACOs, all of that. So all of that matters. But I think it's up to each of us to keep geriatrics front and center, you know, and we often have to remind people, you know, and you don't want to be tugging, but I think we are important, and we really bring so much value, and we should be proud of who we are. We really should.
Absolutely. Well, that seems like a really great place to end. So
okay.
really appreciate your wonderful talk and your time. And yes,
thank you. I feel like saying, and to all a good night, right? Because it's 8 o'clock here, but to you all a good evening. Thank you very much. And I look forward to seeing many of you in the next couple of days.
Terrific. Thank you.
Okay. Bye-bye.
Bye-bye.